common flu that we create. So there are other things that we also can utilize from the patient's physiology to tell us that the patient might have a disease process. We call these signs and symptoms. A symptom is what the patient has to tell us, okay? So the doctor does not go out and say, oh, I think you have a disease, come and see me. If they did, that'd be a little concerning, okay? We call those snake oil salesmen. But usually how we get engaged in the healthcare system is we don't feel well. We feel that there's something wrong with our system. That's a sign, okay? Or excuse me, that's a symptom. A symptom is when I feel something that is wrong. Symptoms come from the patient, okay? That's what a symptom is. It's nothing I can truly measure. A symptom isn't something I can measure. It is a statement or an evaluation by the patient that they inform me of regarding, that can give me hints regarding their health. So for example, chest pain technically is a symptom. Even when I have you rate that pain, that's not a sign, that is a symptom. Because if you tell me my pain is a 5, what does that really mean? Okay, that pain scale that we use, on a scale of 1 to 10, what is your pain? That pain scale we use is totally subjective to the patient. Your 5 might be my 3, okay? The reason why we have the patient number it is so that when we treat them for the pain, we can tell, are we getting better or are we getting worse? The number has really no meaning. The number just tells me where are we starting, so that if I give you a pain med, do we shift that you're having more pain, which means the pain med isn't working, or does your number come down, which means the pain med is working? It's totally subjective. It has no real life, physical, quantifiable number or meaning. It's basically what you say, okay? And no, men do not have lower pain tolerances, and I've talked about this before. That whole thing, men have lower pain tolerances than women, is not correct. It's just that men's pain tolerance is more subjective because we don't have an understanding really of what 10 is. A 10 on the scale is supposed to be the worst pain that you can imagine. And for most men, we don't have a 10. We don't have anything that we can compare to. And we noticed that before about the mid-20s, men and women's pain scale for like injuries is pretty much equivalent. They're about the same. Then after the mid-20s, all of a sudden, women's pain scales go way down and men's pain scales stay about the same. And that's because at that time, most women, or majority of women, start having children, and all of a sudden that childbirth is, that's a 10. You have something that's very, very quantifiable what a 10 is. And a guy is, well, I hurt my foot, I stubbed my toe, right now that's a 10. Because I don't have a quantifiable scale of what 10 was. But anyways, I digress. That is a symptom. I feel short of breath. Short of breath is a symptom. I feel dizzy. Dizziness is a symptom. I feel lightheaded. I feel confused. I feel weak. I feel cold. Those are symptoms. I can't quantify if that's true or not. I'm taking your word for being true. Okay, I'm taking your word at face value. Okay, you tell me you're in pain, you're in pain. That's the first time people come into the medical system, is they have some sort of symptom, generally. Now, of course, we do have well checks and things like that, but the majority of time when you go see your doctor, it's because you have a symptom. Now, the symptom isn't enough for us to diagnose you, but it gives us a hint of what our diagnosis should look into. For example, if I go to my doctor and I say, oh, my head hurts, it's just so much pressure here, I feel like I can't breathe, my nose is dripping. Those symptoms, because no one can qualify that or quantify that. So those symptoms should tell my doctor that they should start looking for what problem? Sinus problems, cold, maybe COVID, in the world of COVID, maybe flu, something like that, right? But if they say, oh, okay, let's check your arm. I think you have a broken arm. Something's off. Okay? The symptoms tell us where we should start to be looking. That is going to be our first guide. The second guide then is our signs. And signs are things we can measure that are not subjective to the patient. Okay, so a sign is something that we can measure. Blood pressure is a sign. Heart rate is a sign. Respiration rate is a sign. EKG tracing are signs. Signs are something that are verifiable external to the patient. Okay? Clear mucus, runny mucus from the nose is actually a sign. I can see the nose dripping, I can see this clear runny mucus. That is a sign. It's something that I can verify without the patient. And the sign gives us more details or more information about what is going on in the body. And it's a little bit more precise, okay? So for example, a patient comes in and they complain of chest pain, shortness of breath, lightheadedness, and I say, you might be having a heart attack. Those are symptoms associated with heart attack. Let's look for some signs now. What is your heart rate? What is your blood pressure? What is your saturation? What is your respiratory rate? Okay, let's run an EKG. What is the rhythm? Those are signs that can tell us if you're having a heart attack. And signs and symptoms should guide us to a proper diagnosis. Okay, they should bring us to the most likely outcome. That's all a diagnosis is. A diagnosis is basically an educated assessment of your current condition. That's what a diagnosis is, an educated assessment. Is it 100% accurate? Not all the time. But with more tests and more signs and more symptoms, our accuracy goes up. So if you just come in and you're coughing, you have a sore throat, your nasal passages are swollen, your drippy nose, your eyes are watering, there are several diagnoses that are possible. Allergies would be one. Cold, or an adenovirus basically, flu, COVID, RSV. So there's lots of possibilities there. So now I have the sign, I have the initial signs, I have the initial symptoms, then I'm going to start running tests. We're going to take a nasal swab. We're going to test for flu and for COVID through nasal swabs. If one of those comes up positive, I know that is my diagnosis. It was one of many, but now it came back positive for COVID. Okay, your diagnosis is COVID. But how about if both of those come back negative? I got sick over the holiday. Really, just coughing, really congested. I'm like, oh, please let it not be COVID. My children are down here. I want to spend time. So I go immediately to the doctor and they do the swabs, and it was negative for COVID and the flu. So I said, good. Now what's the problem here though? We still don't know what it is. We don't have a differential diagnosis right now. We just know it's not COVID or the flu. And so what do they say? It's probably a virus. You know what a virus, the definition of virus is? Your guess is as good as mine. It's when they say it's probably a virus. We could continue to test and test and test and test to find the exact virus that's infecting me, but does it really matter? No, because the treatment is the same. Okay, but the goal here was to use our signs and symptoms to rule out those things we could treat, and then when we ruled those out, we're like, it's just a virus that'll run through your body. If you get worse, come back in. No, just bundle up and then take care of yourself. So we use signs and symptoms to figure out what the possible problem is or what the true problem is, and then we go from there. The last thing I want to do is bring a patient in and start doing very expensive tests that are going to take me nowhere. Okay? I don't want to do that. That's expensive. It's a waste of resources, manpower, money. It's a waste. So what we want to do is we want to use data from simple tests before we start to order very complicated tests. Okay. We want to do simple tests before we do complicated tests, or that should be our goal. So a patient comes in with chest pain and shortness of breath, do I immediately rush them to the cath lab? No. That would be inappropriate. I'll give you another example. Myself. I have a condition with my heart, I think I talked about it. I have a strange condition with my system. It doesn't work right. But I started having issues when I was 15, 17 years old, where I would get short chest pain and feel like I was going to pass out. And so we'd take me to the doctor. One time I was taken to the emergency room, and they could have thrown me into a cath lab right then and there. Oh, you're short of breath, you're having chest pain, you feel like you're going to pass out. Let's rush you to the cath lab to see if you're having a heart attack. Would that have been the best thing for a 15 to 17-year-old?
No.
Why not?
Too young.
Was that?
I said too young.
Yeah, the likelihood of a 15 to 17-year-old having a heart attack is almost nil without other conditions that would have already been diagnosed. It would be very unlikely. So they did EKGs first, they did observations and things like that before we went anywhere else, and that's appropriate. So we want to use cheaper types of evaluations to identify patients who could possibly have a problem before we get too aggressive. The reason I go through all this is because heart sounds are a very important factor in interpreting and in identifying the potential pathologies that exist in a patient. Unfortunately, it has become a lost skill in many ways. Physicians are we note that physicians are having harder and harder time with heart sounds because we get so caught up in these fancy pieces of equipment, these monitors, these systems, that we lose the ability to actually listen. Not only that, our current age of technology, what do we always put into our ears?
Earbuds.
Earbuds, they're very bad for your hearing. Headphones and earbuds are really, really hard on your hearing. And so we notice that more and more physicians are unable to accurately hear heart sounds. Okay. Earbuds and headphones earbuds are worse than headphones. And believe it or not, noise canceling headphones are hard on your ear because there's no equalization of pressure from the outside when you're listening to music. It's kind of suction cups to your ears and it blocks outside pressure, which can cause hearing issues. But I'm not here to talk about that. We're here to talk about heart sounds. Heart sounds are very important because they can tell us what is happening in the body or in the vascular system, specifically in the heart. It can really tell us a lot about what's going on with the health of the heart, specifically structures. Heart sounds are not helpful for coronary artery disease. Heart sounds are not helpful for ischemia, injury, or infarct. In most cases, there are a few exceptions to that, but in most cases, heart sounds are not going to be helpful for ischemia, injury, and infarct, with a few variations there. Heart sounds are very helpful, though, in identifying structural function of the heart. How are the structures of the heart performing? So, let's ask the very first silly question. How would you describe the normal heart sounds? When we listen to a heart, what does it sound like? Lub-dub, 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 lub-dub. We call it lub-dub. L-U-B-D-U-B, lub-dub. Lub-dub, 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 lub-dub. And we hear those distinct sounds. Lub-dub, 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 when my heart is beating. What causes those sounds?
Blood flow.
It's not the blood flow.
Lungs.
Okay, so closure of the valves. Okay, so first of all, let's go through some of these answers that I'm hearing. Your blood flows in what format in the blood vessels? We used this word before. How does blood flow through your blood vessels?
Laminar.
Laminarly. Laminar flow makes no sound. Turbulent flow creates sound. When the blood starts mixing, that's what creates sound. Laminar flow is silent. Okay? So flow of blood should make no sound in the body. So it's not the sound of the blood entering or leaving the heart. That should make almost no sound. If it does make a sound, if the blood does make a sound, we actually call that a murmur. That's what a murmur is when the blood starts to make sound. It is a turbulence. And we'll get into that murmur next week. We'll talk about murmurs on Monday. But murmur is blood turbulence in the heart. Does anyone know what we call blood turbulence in the arteries? There's a murmur when it's in the heart, but what do we call it when it's in the arteries? Okay, so a murmur is the blood turbulence in the heart. What do we call when we hear blood turbulence in a blood vessel, particularly in an artery? Because it wouldn't happen in a vein. It can't happen in a vein because there's no pressure in the vein. If you don't have any pressure, you can't have turbulent flow. So we don't hear this in veins. But what do we call when we hear turbulent flow in an artery?
The thrill?
That's a feeling. Thrill is a feeling.
Brewing?
Brewing, that's what it is. B-R-U-I-T, brewing. And a thrill is the feeling of turbulence in the blood vessel, which means if I had turbulent blood flow in my brachial artery and I put my fingers on that brachial artery, I would actually feel a vibration. That's called a thrill. You would feel a brrr under your fingers. If I listened to it, I would hear a percolating sound. A percolating sound. That's called a brewing. When we hear that in the heart, that is called a murmur. So a murmur is the sound of turbulent flow in the heart, and a brew is the sound of a turbulent flow in a blood vessel. We usually hear it like, and if they listen to the femoral vessel, there's a blockage there. If we listen to your carotid, there's a blockage there. They'll talk about a brew. Okay. But otherwise, in a normal heart, we should not hear blood flowing. So we still haven't answered what is caused by. Now, it's not caused by, we'll get to that in a second too, it's not caused by contraction. Muscle contraction is silent. Muscle movement is silent. Hold up your hand here, hold up your arm like this, and flex that arm. Do you hear a doop, 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 doop? Do you hear any sound? You're going to hear my elbow crack. I mean, that is my skeletal. That is my, my bones scraping against each other. Okay, the tendons popping. Okay, but it's not the muscle movement. Muscle movement is silent and efficient. So it can't be muscle. It's not pressure because pressure makes no noise. Right now, you have a tremendous amount of air pressure on you. Can you hear it? Pressure itself makes no noise. People say, well, maybe it's the opening of the valve then. Opening a door, if it's well oiled, does it make any noise? No. It makes no noise. I will be very honest, I was a good kid. I never tried to sneak out of my house. My brother, on the other hand, did. And he knew which door opened the silentest, the quietest. He knew which one was hard to detect when it's opening. Because a good, well-oiled door, when it opens, doesn't make any sound. So when does something make a sound? When the door shuts. It's not when a door opens, it is when the door shuts and you hear that as it hits or latches into the doorpost. Valves are the same way. When we hear dup, 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 what we're actually hearing is closure of the valves. Okay? So what we call the normal heart sounds is caused by valves closing. What you're actually hearing is valves closing against each other, not opening. You don't hear anything when they open. When they close, that you hear the sound. So with heart sounds, we do this funky little thing. We create these things called sonographs. It is a picture of what the sound looks like. And what you can actually do is you can put a little speaker system on a stethoscope and a little phonographic recorder, and it'll show you the sound imprint of the heart valves opening and closing, and we can create a picture of the sounds. We're going to do a lot of these, what we call sonographs, which is sono meaning sound, graphs meaning image of. We're going to be creating a lot of these sonograms, taking a picture or creating a picture of the sounds, what they would look like. And it just helps us a little bit better understanding what's happening if we can see it. If you hear something, it's hard to differentiate. But when you see it, it's a little bit easier. So there are a lot of good resources that I have linked down here, and we'll be utilizing some of those today. Turn this up because these are quiet. These should work. Now, if you just heard this, it's kind of hard to figure out which one is lub and which one is dub. And it's important for us to know. In the normal heart, when you're listening to the heart sound, you'll hear two distinct sounds, a lub and a dub. Each of those sounds is created by a closure of one of the valve types. So which one is which? When we talk about normal heart sounds, we have two heart sounds that we label S1 and S2. S meaning sound 1, and S2 meaning sound 2. Now, verbally, what we say is sound 1 is the lub, and the sound 2 would be the dub. lub-dum, lub-dum, lub-dum. S1, the first heart sound, is created by the closure of both of the AV valves. S1 is the closure of the AV valve. S2 is created by the closure of the semilunar valves, aortic and pulmonic. So the first sound you hear is the AV valves closing. The second sound you hear is the semilunar valves closing. Well, based upon that information, we can go a little bit further. S1 signals the end of diastole and the beginning of LV contraction. Because remember, the valves close because of a change in pressure. A change in pressure is caused by ventricle contraction. So S1, when the AV valves close, those valves close because the pressure in the ventricle has increased, forcing those valves shut. That it means if those valves shut, diastole is done. We can't get more blood into the ventricle naturally, normally, because the pathway for blood getting into the ventricle is cut off. And that is cut off because the ventricles have begun to contract and the pressure has increased. Similarly, S2 is the end of diastole. Excuse me, I'm sorry, end of systole. Sorry, it's on S1 still. But we can't say that LV, left ventricle filling has started yet. LV filling does not start when the aortic valve closes. LV filling starts when the mitral valve opens, but there is no sound normally associated with that. So when we hear S1, we know diastole has ended and the ventricle has begun to contract because that is what will close the AV valves. The increase in pressure in the ventricles will slam shut that AV valve, so we know that diastole is completely finished and the LV has begun to contract. However, when the semilunar valves close when the arterial pressure is greater than what the ventricle can produce anymore. But that does not mean the ventricle starts to fill right then, because there's that isovolumetric relaxation period that still has to occur. So the only thing that we can tell with S2 is that we are at the end of systole. Does that make sense to everybody so far? This is going to become an important concept that we have to get into our minds before we go on, otherwise things get very confusing. So S1, diastole is done. S2, ventricular systole is done. That means between S2 and S1, the ventricle is contracting, and we have systole. And between S2 and S1, we have diastole. So between S1 and S2, we have systole, and between S2 and S1, we have diastole. The problem I have right now is which one is S1 and which one's S2. How can you determine this? Now listen, because in the real world, that's all you have is your ears. How do I know which one is S1 and which one is S2?
First one is the love.
But which one is love?
The first one.
Okay, but how about if okay, close your eyes for a second. I want everyone to close your eyes. Close your eyes. Okay? Tell me which one is lub and which one is dub. The first sound that you heard, was it lub or was it dub? Close your eyes.
Dub. Dub.
The first sound you hear, is it lub or dub? Close your eyes and tell me, oh, let me play it. The first sound that you heard, was it lub or dub?
Dub.
It was dub. It was dub. So you can't say lub dub because most of the time when I play it, people cannot pick out lub or dub. And that's on a digital. Imagine listening to a real person's heart, which I have somebody bringing stethoscopes. We'll do that. Imagine listening to somebody's heart. So how are you going to determine which one is lub, which one's S1, and which one's S2? Well, there's a very simplistic way of doing this. Is your heart in systole or diastole longer?
Diastole.
Diastole. So when you're listening to the sounds, you have to listen to the space between sounds. When the space between sounds is longer, one is S2 and one is S1. So if the space between sounds is longer, the sound before that long space is S2, and the sound at the end of that long space is S. Oh, thank you. If the space between the two sounds is longer, the sound before that long space is S2, the sound after that longer space is S1. If the time interval between the two sounds is shorter, the sound before that short interval is S1, and the time at the end of that short interval is S2. So it's not just listening to the sounds, it's listening to the spacings of the sound. If there's a short spacing between two sounds, the first sound is S1, the second sound is S2. Lub-dub, pause, lub-dub, pause, lub-dub. That's a short spacing. And the first sound between those two is S1, and the second sound is S2. Now when the pause is longer, dum, lub-dum, lub-dum. That longer pause, the first sound before that long pause is S2, and the second sound is S1, because that between S2 and S1, I'm in diastole, which should be a longer period of time. Between S1 and S2 is systole, which should be a shorter period of time. If I were to draw this out with a phonograph, what we would visualize is the following. So the space between S1 and S2 is shorter than between S2 and S1. And S1 is generally a little bit louder than S2. And we can see this if we go to your module. We can see it here. S1 and S2. The space between S1 and S2 is shorter than between S2 and the next S1, and S1 is louder than S2.
So it's louder and it has a higher pitch.
Yes, generally. In the normal heart, generally, yes. Okay. Now, I would say higher pitch, but I wouldn't necessarily louder, because loudness, or what we would consider volume, is going to be dependent on where you listen on the chest. Now, if you've ever been to a doctor's office, what do they always do with that dang cold stethoscope? Yeah, they say, okay, try to breathe normally, and they put that cold stethoscope on your skin, and you're like, because it's freezing cold, and you're like, there's no breathing normally here. When they're listening to the front of your chest, they're listening for the heart, because your heart is more anterior. What do they listen to when they're listening to the back of your chest? The lungs. Your back is your lungs, the front is your heart. And when we're listening to your heart, there are 4 points that we generally listen to. Okay? At the third intercostal space, right below the thickness of your sternum here. On the left and right side of your sternum. On the right side of the sternum, that is your aortic point. On the left side of your sternum is your pulmonic point. So when I listen up here, I hear the aortic sounds better. When I listen over here on the left side, I hear the pulmonic sounds better. That's a pulmonic valve and aortic valve. I can hear them better. The other spaces I have are kind of in the fourth intercostal space, and then in kind of the fifth intercostal space, both on the left side of the sternum. Here, I hear the tricuspid valve better, and here I will hear the mitral valve better. Okay. That's something called Erb's point. We'll get to Erb's point later. We're going to listen here, 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 and here. Now you might be looking at this and saying, wait a minute. This chart has to be backwards, right? Because on what side of the chest am I listening from my aorta? No, look at my screen. On the right side of my chest, I'm listening to the aorta. Where am I listening to the pulmonary artery? On the left side. And when I listen to the tricuspid and the mitral valve, I'm all on the left side of my chest. You might say to yourself, well, Mr. Ho, you have it backwards because the left ventricle and the aorta come off of which side of my heart? The left. And my right ventricle is on what side of my heart? The right. So why am I listening to the opposite side? Look at my heart here. My aorta, as it comes off my left ventricle, is actually on what side of my sternum? My aorta is on the right side of my sternum. Mm-hmm. My pulmonary artery is on what side of my sternum? The left side, because they cross. So if I want to hear the aortic valve, I need to be on the right side because I hear the valve as it's going towards the stethoscope. So listening to the aortic valve, I need to be on the right side of the chest, right next to the sternum, because how the aortic valve comes off. To hear the pulmonic valve, I need to be on the left side of the sternum. And because of how my heart is situated in my body, both my tricuspid and my mitral valve are more towards the left side of my chest. My tricuspid valve is right here. Oops. My mitral valve is here. All on where this heart is.
And is that we listen to it through the fourth intercostal?
Yeah, well, right here, yeah, fourth intercostal space, right here. So if you look at this, my aortic valve is here. My pulmonic valve is here. My tricuspid valve is here. and mitral valve is here. So when people say that, when they say this makes sense, this doesn't make sense, but when you put your heart up here, it makes perfect sense about where all of my valves really are.
And we just place it right there and you can hear
Yep.
both.
But we have to listen to the tricuspid here, and on the left side, not on the right side, left side. Tricuspid and the fourth intercostal space. And that's why they listen up here and here, and that's why they move the stethoscope here, 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 and here. Kind of makes a strange pattern. And we'll practice. I'm going to try to get some stethoscope. If I don't get it today, I'll get it next week, so you can practice. Okay.
I've got a couple at the house if you need some.
No, that's okay. We have some here. I just have to wait for them to deliver it. So that's what they're doing when they're listening to your heart. And when you say it's louder, well, it's louder depending on where you're located. If I'm listening to in my aortic valve position, will S1 or S2 be louder?
It's two.
S2 will be louder. If I'm listening to my pulmonic valve location, will S1 or S2 be louder?
It's two.
S2 will be louder. If I'm looking at my tricuspid valve location, will S1 or S2 be louder?
S1.
S1. If I'm looking at my mitral valve location, will S1 or S2 be louder? S1. So when you said it's going to be louder, not necessarily. It will be louder depending on what position you have the stethoscope in. Will it be higher pitch? Yes, S1 will be a higher pitch, but we can't say that it is louder because loudness is going to be dependent on location. Now, there is something else that we need to be made aware of. When you hear the sound effects are free, by the way. You're hearing both valves close simultaneously. You're not just hearing one valve, you're hearing both valves close simultaneously, which is why we want to use different locations. When I'm over here, the loudest part of S1 will be the tricuspid valve. If I'm over here, the loudest part of S1 will be the mitral valve. Does that make sense? Because I can't differentiate it unless I'm in the correct position. The loudest one will be where I'm located. If it seems abnormally loud in the tricuspid valve, when I move it to the mitral valve and I hear the loudness, I'm listening to the mitral valve closing. Okay, there is something weird that happens. S2 splitting. Okay, so S2 splitting. When we talk about S2 splitting, what will happen? And this is normal. When a patient takes a deep breath, when they're listening to your heart, you might hear them say, "Take a deep breath for me." And when you're taking a deep breath, S1 will stay the same, but S2 will split into two different sounds with a deep breath. S2 will split into two distinct sounds of deep breath. You'll hear a lump, 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 lump. You'll hear two dubs really close together. They almost sound like they're unified, but they're really close together. So normally you'd hear a lump, dub, lump, dub, lump, dub, lump, dub. When take a deep breath in, lump, dub, lump, dub, lump, dub. Let it out, lump, dub, lump, dub, lump, dub, lump, dub. Take a deep breath in, lump, dub, lump, dub, lump, dub. Breathe out, lump, dub, lump, dub, lump, dub. This is called normal splitting. And what happens is when I take a deep breath in, we have what we call an A2 sound and a P2 sound. A2 and P2. What do you think the A2 stands for?
Aortic.
Aortic. What do you think P stands for? Pulmonic. When you take a deep breath in, normally, this is normal, when you take a deep breath in, the pulmonic valve closes after the aortic valve, and this is normal when you take a deep breath in. And you might say, but why is it normal? That doesn't make sense. And it doesn't. Because up to this point, we've been telling you that the ventricles contract at the same time, they stay contracted at the same time, the valves open at the same time, and they close at the same time. Except when you take a deep breath in. When you take a deep breath in, what happens to the pressure in your chest?
Increases? No, decreases.
It decreases. Since the pressure in your chest decreases when I take a deep breath in, the ventricle, the right ventricle, let me say it this way, the afterload to the right ventricle decreases. The pressure in my chest when I take a deep breath in decreases. The afterload to my right ventricle decreases, so the valve can stay open longer. When I take a deep breath in, does anything happen to the afterload of my left ventricle? No. My left ventricle is pushing blood to my head, nose, toes, and everything in between, and taking a deep breath does not change the resistance of any of those tissues. So the left ventricle is meeting the same afterload, which means it's going to close at the same time it always does. But the pulmonic valve, when I take a deep breath in, the pressure in the chest goes down so much that the afterload closing that pulmonic valve decreases, so the pulmonic valve stays open longer. And so we call this normal splitting. This is normally what will happen. When I take a deep breath in, the right ventricle should normally be able to contract longer, not much longer, we're talking milliseconds here, but slightly longer than my left ventricle because of a change in afterload because of the deep breath. So when I breathe out, the pressures, the afterload to both, are equivalent to each other. So I'll hear a because the valves will close simultaneously. But when I take a deep breath in, the afterload to my right ventricle is significantly different. The afterload to my left ventricle hasn't changed, and so we'll hear a slight space between the closure of the aortic and pulmonic valve. We hear and when we breathe out, so when I breathe in and out, I will hear that splitting. And that is normal. Make sense? Okay. So if I hear those sounds and I hear nothing else, all right. Okay, good. So when we start hearing other things that we have to say, something weird is going on. So let's take a break and we'll come back and start talking about weirdnesses.
So
Oh, by the way, when you're breathing in, if you're listening to the pulmonic and aortic space, you'll hear the pulmonic valve louder in the pulmonic space. And so when they tell you when they're listening to the aortic space and they say, listen, take a deep breath in, they're listening for the aortic sound. And when you take a deep breath in over here and they're in the pulmonic space, they're listening for the pulmonic sound. So that's why they do that. They're trying to differentiate which one's louder and which one's quieter.
then do you have the mitral one?
No, there's no split for the mitral valve because the resistance to both of those is equal to the ventricle's filling, so that doesn't change. Because the afterload, what closes the valves of the, say that again, what closes the AV valves is when the ventricles start to contract and the pressure increases, which should, in normal heart, occur simultaneously whether you're breathing in or breathing out, because that's dependent on the electrical conduction, not on pressure. So, no, because those valves close when the ventricles start to contract.
So you say like when you take a deep breath in, the right ventricle, the afterload in the right ventricle decreasing, right? And
Yes.
the left ventricle, it
It
remains the
stays
same.
the same, yeah.
But the thing like, it doesn't, the right ventricle, left ventricle is still in thoracic cavity, so.
Yeah, but the left ventricle, it's what you're pushing against. Remember, the left ventricle is pushing against, it's all the arterioles put together is what determines afterload.
Okay,
So your lungs, your right heart is only pushing against the capillaries in your lung tissue. The left ventricle is not pushing against any capillaries in your lung tissue, it's pushing against the capillaries throughout the rest of your body.
okay.
So the breathing will not have an effect on the left ventricle. Normally. It's a nice beat, you just really can't dance to it. So it's splitting sounds like.
Sounds the same for me.
This is normal. Oops, that's not normal. This is normal. This is splitting.
Yeah, it's rumbling by.
There's a double on the second sound. A little bit of a rumble. In marching band, this will drive you nuts because it means one of your drummers is off.
So like on a dog, it take them a while to get used to this sound, right? You know, like,
And fewer doctors are able to master it.
can you go over like the S1, S2 loudness, like when you put like pulmonary, like aortic pulmonary tricuspid mitral thing? You say like S1, like S1 from.
This one will be louder down here. S2 will be louder up here.
Oh, both?
Well, yep, because they're both part of S2. So S2 will be louder in the atrial and pulmonary positions. S1 will be louder in the tricuspid and mitral positions.
Why is that?
Because you're right over that valve. Here you're over the aortic and pulmonic valve, so those valves are gonna be the loudest. So that's S2,
Why you loudest?
because you're right over that valve.
Because S2 is only aortic and pulmonic, right?
What's that?
So S2 is only.
It's always says only aortic and pulmonic. So if I'm right above that, that's the sound I'm gonna hear the loudest, because I'm the
Okay.
closest to those.
Okay,
S1 is gonna be created down here, so further away, so you always hear the thing that's closest to you louder.
okay. But you, let's say you put the saxophone higher.
It's not gonna help, you have to put it in the actual position.
Oh, that's.
Because you're right above the valves. These are the locations right where the valves are located.
Okay. I thought it sound like echo out, you know?
Nope.
No?
Does not echo.
would this be like a person, say, in exercise?
This is just recording somebody who took a deep breath.
That's just one deep breath.
Yep. It's just looping over and over again. So that is the splitting.
Is it typical during like
Nope.
heavy breathing and exercise to have like that S2?
So anytime you take a deep breath in, you'll hear it. So when you're exercising, it's only when you're breathing in that you would hear it. For that short minute you're breathing in, that's the only time you hear it. You only hear it while you're breathing in.
So when the doctor tells you to take a deep breath in and hold it,
When you say taking a deep breath in and holding it, it's not gonna keep a split. When you're taking the deep breath in, it'll split. When you hold the deep breath, what you're trying to do is get rid of the lung sounds. Because when you're breathing in and out, you have lung sounds that overlap the heart sounds.
okay,
So when they tell you to take a deep breath in, you're listening for the split. When they tell you to hold it, then they're eliminating the lung sounds, and they won't hear the split anymore, but they will be able to hear the S1 and S2 clearly.
That's the one that you said was
This is split.
S1 and split.
Yeah, S1, S2 is the second one is the split. So it's A2, P2. A2 is always the first. Okay. This is what it sounds like when a person takes a deep breath in. Okay. Now, let's start talking about abnormalities. Abnormalities, we have paradoxical splitting. Paradoxical splitting occurs when you hear the split when the patient breathes out during expiration, I should say expiration and inspiration.
These are abnormalities.
Yep, this is an abnormality. When the person expirates or exhales, and you hear the splitting. So when we have paradoxical splitting, there will be no splitting during inhalation. But the sound is heard after they exhale. That's abnormal. You should hear the splitting when you inhale, not when you exhale. So when you inhale, you hear lup dup, lup dup, lup dup, lup dup. And when they breathe out, you hear a lup dup, lup dup, lup dup, lup dup, lup dup. When they breathe in, lup dup, lup dup, lup dup. And when they breathe out, lup dup, lup dup, lup dup. That's opposite of what's supposed to be happening. That is an abnormality. And there are a couple of things that can cause that. Aortic stenosis and left bundle branch block. Okay. Aortic stenosis and left bundle branch block would cause that. And in both those cases, with aortic stenosis, because the valve is smaller, the ventricle will be forced to contract for longer periods of time to get the same amount of blood out of the valve. So when they exhale, the pulmonic valve is going to close before the aortic valve because the ventricle is going to have to contract longer to get the same amount of blood out of this small aorta. With left bundle branch block, the electrical stimulus gets to the left ventricle after the right ventricle. So the right ventricle will contract earlier than the left ventricle, and we will have that splitting because of that separation of contraction. So if the patient exhales, then you hear the lup doo, lup doo, lup doo. They either have aortic stenosis or left bundle branch block. Left bundle branch block can be identified through an EKG. Aortic stenosis is going to require a little bit more evaluation. Fixed splitting. Fixed splitting is a separation of S2 that occurs whether they're breathing in or breathing out. It's always there. When they breathe in, you hear a lup-doo, 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 lup-doo. That would be normal, except when they breathe out, you still hear a lup-doo, 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 lup-doo. They breathe in, lup-doo, lup-doo. When they breathe out, lup-doo, lup-doo. You're like, there is no difference here. I hear that double sound in both situations. That is abnormal. And that is caused by an atrial septal defect. We'll get into that later. There's a hole in the atria that's causing more blood to accumulate on one side of the heart than on the other, and that will cause one of the ventricles to be overfilled, and it will change how long it takes to contract and empty. So if you have an atrial septal defect, one ventricle has more blood in it than the other ventricle, and therefore it will always take longer for that ventricle to empty. And that way the valve will stay open longer than the other one, no matter what.
Is that the foraminal valley?
It could be a foraminal valve. That's one of the things that causes it. Any septal defect, any hole in the atria, whether it's in the foraminal valve or somewhere else in the atria, would cause a splitting. And it's constantly there. So normally it would be lub-dub, 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 take a deep breath in, lub-dub, 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 breathe out, lub-dub, 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 take a deep breath in, lub-dub, 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 take a deep breath out, lub-dub. Paradoxical splitting, aortic stenosis or left bundle branch block. Breathe out, lub-dub, 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 breathe in, lub-dub, 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 breathe out, lub-dub, lub-dub, lub-dub. Fixed splitting, breathe in, lub-dub, 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 breathe out, lub-dub, 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 breathe in, lub-dub, 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 breathe out, lub-dub. It doesn't change. Okay? Those are abnormalities. Now, S1 and S2 are not the only sounds that our bodies can produce. Our hearts can also produce what we call extra heart sounds. This gets a little bit weird. I'll be very honest. This is going to make your head hurt a little bit because of where they occur and what's going on. So let's talk about one of the most common extra heart sounds. S3. S3 is a very dull, low-pitch heart sound that we can hear after S2. It occurs right after S2. So you hear a lub-dub, 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 lub-dub. It's a very low, quiet sound, and it comes right after S2. Yes?
And it's a longer period compared to splitting, right?
Yep. It would occur after the split. So you'd have lub-dub, 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 lub-dub. sound effects are free. I practice this a lot, by the way. So it occurs after the splitting, after any time S2 is occurring, it occurs after S2 and it's really quiet and it's really dull. It's not this sharp lump that has this, personality to it. I don't know if that's, you can have a personality for a sound, but the sound is very quiet, very low. And there is a small pause between. Okay. There's a small pause between S2 and S3. Lum, lum, dum, lum, dum, lum, dum, lum, dum, lum, dum. Very small, very low pitch sound. We usually hear it best in the mitral valve position. So S3 is heard best in the mitral position. So right about here. You can hear it best right about here. And the mitral valve, oh, it's a little too far, about right here. Okay. Very low. Now, oddly enough, this is considered normal in adolescents and young adults. Although in older adults we get a little bit concerned. In adolescents and young adults, what causes this is we believe it is the tension building up of the papillary muscles. The ventricle is filling so rapidly, so healthily, that the chordae tendineae and the papillary muscles stretch, and you can actually hear that. What you're hearing is the sudden snap or stretch of the papillary muscles and chordae tendineae as the ventricle fills. And when you're nice and young, your ventricles fill really very quick or very quickly. And so you hear this little, as those papillary muscles and the chordae tendineae stretch very, very quickly. Okay? And it's considered a normal finding.
More turbulent flow then?
Nope, it's not turbulent flow because it's not a murmur. You're actually hearing the muscles. For example, can I use this for a second? Can you kind of hear this? Oops. Hear that sound? It's very quiet. That's what you're hearing, is the papillary muscles and the chordae tendineae suddenly tensing up. Okay. Now, in older adults, I'll move that up. In older adults, what this could mean is a dilated ventricle. In older adults, it signifies a dilated or enlarged heart. So if you're a young adult or a teen and we hear this, we're like, hey, you got a good healthy heart. If you're 60 years old and we hear that, we're like, let's take an x-ray. How big is that heart? Could be a sign of an enlarged or dilated heart. Now, if you hear an S3 heart sound, sometimes they will call this a ventricular gallop.
An S3 gallop, or third heart sound, is a sound that occurs after the diastole S2 dub sound. In young athletes or pregnant
Pregnant
older
women,
adults,
that's
it
true.
may indicate heart disease. This answer is from healthline.com.
Thank you. You're just qualifying. It is, and it has, but it can be heard in pregnant women. We don't hear that often. They can be heard in pregnant women because of the the volume overload caused by pregnancy, the increased circulating volume. Okay. So not a big deal to hear an S3 heart sound. Gallop. Ventricular gallop. Yep.
That's the
What
other
did you
name.
say about that?
That's the other name for it. That's what we call it if we hear it.
Oh.
Because you have
Oh, the extra heart sound is the ventricular
Yep.
gallop.
So that's an
Sounds like a
S3,
horse, yep.
That's S3, okay.
sounds like a horse. Okay. That's S3. We also have an S4. S4 occurs late in diastole. S4 is a dull heart sound that occurs right before S1. And we hear it at the end of diastole. Again, it is low, very dull pitch. We have S4, S1, S2. S4, S1, S2. S4, S1, S2. So it occurs right before S1. S3 occurred right after S2. S4 becomes before S1. And no, you do not have to have S3 to have an S4. S3 and S4 indicate their location, not the requirement that you have one and not the other. So if you remember, S3 sounded lub doop, lub doop, lub doop. What this sounds like is doop lub dum, doop lub dum, doop lub dum, doop lub dum, doop lub dum. So it occurs right before S1. Doop lub dum, doop lub dum, doop lub dum, doop lub dum, doop lub dum. Whereas S4 is lub dum doop, lub dum doop, lub dum doop, lub dum doop. The doop is right after S2, whereas then S4, it's right before S1. Doop lub dub. Doop lub dub. Doop lub dub. Doop lub dub. It occurs right before S1. The other one occurs right after S2. This is caused by something we normally don't hear. This occurs when the atria is contracting against a stiff ventricle. Remember, atrial contraction happens at the very end of diastole, which is why this sound is at the very end of diastole. Remember, diastole is most of passive filling, so all of this right here occurs during passive filling. This is the atria contracting right before the valve closes. So what we're hearing there is the atria contracting, forcing blood against a stiff ventricle. The ventricle is really stiff and hard, and the atria is trying to force blood into it. And we hear this tension of this stiff ventricle resisting it. You hear the ventricle going, we're trying to overfill that ventricle. This is not a natural sound. This is an abnormal sound. This is often caused by ventricular hypertrophy. And in some cases, people with myocardial ischemia. When you have myocardial ischemia, the muscle cannot relax as well because it doesn't have the oxygen necessary to trigger the relaxation process. And so it stiffens during ischemic processes. So you get this fourth heart sound. Lub dub, 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 lub dub. The ventricle's hypertrophied, making it more difficult for the atria to contract and empty into it during atrial kick. Oddly enough, this also has a name when we hear it. It is called the atrial gallop. If you have an S4, you have an atrial gallop. So S3 is ventricular gallop. Lub, dub, lub, dub, lub, dub, lub, dub. Yes.
You can get a ventricular septal defect, right?
With S4, not generally with S4.
But would you be able to hear it?
Yes, that's usually going to cause a murmur. We'll talk about those later. Yep. Lub, dub, lub, lub, dub, lub, dub, lub, dub, lub, dub, lub, dub. That's S3. S4 is dub, lub, dub, dub, lub, dub, dub, lub, dub, dub, lub, dub. It's right before S1. Now, what happens when I have all of these together? Can that happen? And the answer is yes. Dublub dub dub. 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 We take a deep breath in. Dublub dub dub. Dublub dub dub. You case practice, do that, the same. So you can have a dublub dub dub. Dublub dub dub. This is called a summation gallop. When you have all four, you have a summation gallop. So it is possible to have all four. Isn't required, but you can. Okay. So we have S1, normal heart sounds. When you take a deep breath, deep breath in, you'll have splitting of S2. You breathe out, it should go back to. If you hear the split when you breathe out and not when you breathe in, that is called a paradoxical splitting. It's until they breathe in, and then when they breathe in, you hear it sign of aortic stenosis. Then you can have a constant splitting, whether you breathe in or out. That's a fixed splitting, a sign of atrial septal defects. You can also have extra heart sound, S3, which when you're young is normal. It's the tension of the papillary muscles and chordae tendineae. When you're old, it is the sound of a dilated heart. and it's just a very low, dull sound after S4, or excuse me, after S2. Love do, 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 love do. It's not a split, it's just, there's a pause between a small pause, but there's a pause between S2 and S3. And you can also have an S4, which is the atrial pushing against a stiff, hypertrophied, or ischemic ventricle, and it occurs right before S1. So that's where people get confused. How does S4 come before S1? It just is. That's the fourth heart sound we heard. So it goes dum-lum-dum, 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 dum-lum-dum. So right before S1, it's very quiet. And of course, you can have all three. Lum-dum, dum-lum-dum, 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 dum-lum-dum. Each one of those indicates a separate problem. But we're not done yet, ladies and gentlemen. Which one do I want to do first? Let's do this one.
And so the S3 and S4 happens during breathing in or breathing out? Or
Doesn't
they-
matter. It's always constant.
Okay.
Because breathing in and breathing out does not change stiffness, and it does not change the existence of a dilated heart. So it doesn't matter. So then we have some things called ejection clicks. Ejection clicks. The first type of ejection click is called an early systolic ejection click. And it occurs right after S1. And it's a very high pitched sound. So it's lop, dum, 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 lop, dum. It's a very high pitched clicking sound that occurs right after S1. This is an abnormality. It is the sound of a stenotic valve opening. Now remember, valves opening should make no sound. It's just that this valve is really stiff, and when you open it, it makes a clicking sound. Okay. Specifically, with the early systolic ejection click, we're talking about aortic or pulmonic valve. It's one of the semilunar valves. AO or PA sound. Look, dum, 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 look, dum. It's a very high-pitched click sound after S1. How do you think I could tell if it's the pulmonic or the aortic valve that is stenotic? Depends on where you hear it the loudest. If you hear it the loudest over the aortic position, which valve is stenotic? Aortic. If you hear it loudest over the pulmonic position, which valve is stenotic? Pulmonic.
Should you ask for a deep breath?
It doesn't matter. The only reason why you would take a deep breath in is to get rid of the lung sounds, so you could hear it clearer. It will not change.
You can separate.
Nope. No. Because this happens after S1, not after S2, and we hear the splitting during S2. You could have them take a deep breath in and just eliminate the sound of the lungs. Okay. So it's quick click right at the beginning of S1. We have another click, another what we call a mid to late click, or mid to late sound. So early systolic click occurs right after S1. Mid to late systolic click occurs closer to S2. So it'd be lub, or lub, dum, lub, dum, lub, dum, lub, dum. Whereas early click is right after S1. Lub, dum, lub, dum, lub, dum. Mid to late click occurs right before S2. Lub, dum, lub, dum, lub, dum. This is caused by something that we call, my brain just went completely blank. Here we go. Okay. So it occurs right before S2, and it is associated with something we call valve prolapse. And what happens with valve prolapse is your AV valve, the leaflets are extra big. And so what happens is when the ventricle contracts, that large valve pushes up and kind of snaps. How many of you ever played like with a parachute when you were a kid? Did you guys in school have parachute day where you played with the parachute and you run under it? When you threw it up and they say pull down, you heard a snap sound when you hear it's a quick snap when you pull the parachute down. That's what the prolapse is doing. The prolapse of the mitral valve is going up and it just stops. So most of our AV valves are very flat, and so they just stop here. But a couple of us, or a few of us, might have very fluffy AV valves, which means they're over large, and when they close, they can bulge upwards more. And then the chordae tendineae snap into place, holding them closed, even though they're bulging upwards like this. So some people are born with extra large valves, extra long valves. So rather than closing like this, they close like this. And that sudden stop creates this snapping sound, and it occurs right before S2. It is very hard, I'll be very honest, I would never ask you to differentiate anyways, but I would never ask you, which one is this? Is this an opening or an early or a mid systolic click? It is extremely hard to differentiate those two. Most cardiologists can't. Most cardiologists will hear a click and they'll say, let's get an echo done. You either have a stenotic valve or prolapse, because it's very hard to hear the difference between the two, because both of them have the same sound to it. So is it right after S1, look, do, look, do, or is it right before S2, look, do, look, do? I mean, there's very little difference in the two. And so the ejection clicks, early to mid systolic, you have a 50-50 shot. It's either a mitral valve, which is either a semilunar valve stenosis or a prolapse AV valve. But there is a way you can try to differentiate it. How do you think I could try, if I can't hear the difference in timing, what could I do to try to differentiate, well, is this a stenotic valve or is this a prolapse valve?
When it is closer to S2?
But if I can't hear the difference, I mean, I can't hear the difference.
The visuals, you said in the beginning you can visualize.
Yeah, but that's only if you hook it up to an audiogram. How many times have you seen your doctor hook your stethoscope up to an audiogram? We don't do that anymore.
Placing the stethoscope next.
It's where you listen to it. If I hear the snap loudest in the aortic or pulmonic area, which of the problems am I dealing with?
Stenotic valve.
Stenotic valve. If I hear it in the tricuspid or mitral valve area, which of these two problems do I have?
Prolapse.
Prolapse valve. So where I hear it, even though I can't really differentiate all the time, is it early or mid to late? If I hear it up here, one of these two valves is stenotic. Which one's loudest? If I hear it better down here, I have a prolapse AV valve. Which one is, wherever I hear it the loudest, oops, I should be hearing here. Wherever I hear it the loudest is the one that's being caused. So I can't hear it just by listening to it oftentimes, but knowing where I'm at and where I hear it the loudest indicates to me that that could be the problem. Okay, I think that is good for, those are what we call the heart sounds. There's also something called an opening snap. We'll talk about that. That's not as important, doesn't occur nearly as often. These are the ones that occur most often. On Monday, what we're going to be talking about is we're going to be talking about the murmurs. Now, opening snaps, S3 and S4 are important to know, but by far, especially on the boards, the real issue is cardiac murmurs. So cardiac murmurs suggest and signify a significant problem. Because this is just hearts, the muscles contracting, the valves aligning. Most of these are pretty mundane, pretty low on the concern board. Murmurs, though, is suggesting that there's something wrong with the function of the heart, that blood is turbulent, blood is not flowing as it should. And that's a much higher concern, and we'll talk about murmurs on Monday. Now, in the meantime, I have an assignment here that will help you with your reading and a couple of other things. So here's, again, where we listen to the heart sounds. Still in the background, sorry. We'll talk about this. This is some of the phonograms. We've talked about first, second, third, fourth heart sounds, but first, second heart sounds, that's the normal. These are different websites that can help you it talks about positioning, heart sounds, kind of how we perform it, where we hear different things. These are kind of good resources. Professional Skill Bundle, which plays the different heart sounds, S1, S2. And this is the one that has the good audio files that you can loop and hear over and over again. But also for your reading, I have this assignment. Oh, that's a good thing too. There's also another YouTube video that does it as well. But here's the assignment. And it's a study packet that will take you through the reading. And if you just answer these questions from your reading, it'll take you through your reading and help you identify specific things in that reading, kind of creates an outline for you. So that is due next week. So not on Monday, it's due, I think I have it due on next Tuesday. Okay? Sound good? Okay, now here's the thing on the test. Do you think I will have you listening to heart sounds?
Yes.
No, I will not.
What?
I will not have you listen to heart sounds. Most cardiologists can't hear heart sounds. I do want you to be aware of them. We will listen to them here. I highly suggest you listen to them to get comfortable in what they sound like. I highly suggest that. But when it comes to, is this an opening snap, closing snap? No. You should understand the phonographs that, the phonograms that we're drawing. S1, S2, S3, S4, what that looks like as we draw them. But no, I will not have you listen to it on the exam. Because how many times do we listen to heart sounds?
Never.
We don't. However, when we read a chart, do we read about heart sounds being heard?
Yes.
Yes. And that's really what we want to know is when they write about a specific, during auscultation, they heard a heart sound, we want to know what that meant. Okay? Okay, that is enough for right now. We'll take a break. We'll meet back at 10 o'clock for a shorter meeting today for our clinical updates and also to talk about what we're going to do for EP. Sound good? Okay, so take a break and we'll meet back at 10 o'clock and we'll have an early lunch after.